1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's,
300 please.
I'll keep you on again.
Pulse check. No pulse.
no more pulse.
Yeah. Where the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
You know, usually when we talk about a medical diagnosis, there's this expectation of, I don't know, absolute precision. It's kind of like engineering. You break your arm, the x-ray shows that jagged white line, and the doctor just points at the film and says, like, there it is, that's the problem.
Right. It's binary. I mean, it's a clear-cut cause and effect relationship that we can see right there with our own eyes.
Yeah. Broken or not broken, you slap a cast on it and you're done. It's clean. And frankly, it's comforting, you know? We like our medicine to be visible. We want our patients' baselines to be static so we can neatly categorize their symptoms into these predictable little boxes.
But then you step onto the labor and delivery floor.
Exactly. You step into the world of obstetrics and maternal physiology, and suddenly that static x-ray machine is just, it's completely useless. You're looking at a diagnostic landscape that is honestly completely wild, because you're looking at a patient whose entire anatomical and chemical baseline is shifting by the hour.
It is the absolute definition of a physiological earthquake.
Yeah.
I mean, as a nurse, you are managing a body that is actively remodeling its own skeletal structure, rewiring its cardiovascular system, and this is crazy, suppressing its own immune system, all to sustain a second, entirely separate life.
And that shifting ground is exactly what we are navigating today. So if you are listening to this right now, you might be gearing up for a major nursing exam, staring down the NCLEX, or maybe you're just about to step onto the OB floor for your very first clinical rotation. Whatever brought you here, we are stepping into the roles of your clinical mentors today.
That's right. And we are pulling all our insights from the Comprehensive Guide to Pregnancy Care and Maternal Physiology. But we aren't just going to, read a textbook at you.
No, definitely not.
Because rote memorization does not save lives in an obstetrical emergency. Understanding the why does.
Yeah.
So our goal, as your coaches today, is to aggressively apply the Pareto principle.
Which is the 80-20 rule, right?
Exactly. We are sifting through hundreds of pages of dense medical text to pull out the 20% of concepts that will give you 80% of your exam value. We're cutting the fluff.
We want to make you a profoundly safe, sharp, and anticipating future nurse. And anticipating is really the operative word here, because when you truly grasp the baseline of maternal physiology, like when you understand how the house is being remodeled, you don't just react to a life-threatening complication. You see it coming from a mile away.
You do. You prioritize your interventions effortlessly because the underlying physiological logic just makes perfect sense.
So to build that logic, I feel like we have to start with the physical transformation itself. Before you can recognize a pathology like preeclampsia or a hemorrhage, you have to master what a normal pregnancy actually looks like, system by system.
And to wrap our heads around that, let's use your analogy. I want you to picture a house. But this isn't just a house getting a fresh coat of paint. This house is undergoing a massive, top-to-bottom structural, electrical, and plumbing renovation.
Yeah, walls are being knocked down to create more space. Pipes are expanding to handle double the water pressure. The electrical grid is just surging. And the real kicker, someone is actively living inside this house while all of this heavy construction is happening around them.
The mother's body is that house. And the plumbing renovation is perhaps the most dramatic shift of all. So let's look at the cardiovascular and hematologic systems.
Okay, let's dive into the plumbing.
By the middle of the third trimester, maternal blood volume increases by 30 to 50% above her pre-pregnant state.
Wait, hold on. 50%. If you add 50% more fluid to a closed plumbing system, like adding 50% more water to a water balloon, the pressure inside that balloon should be immense. Why doesn't the mother's blood pressure absolutely skyrocket?
That is exactly what you would expect to happen in a non-pregnant patient. I mean, if I give you a massive IV fluid bolus right now, your blood pressure would spike. But the pregnant body anticipates this hypervolemia. The hormones of pregnancy, specifically progesterone, cause massive systemic vasodilation. The blood vessels actually relax and widen to accommodate that huge influx of new fluid.
Ah, so the pipes get wider so the pressure doesn't blow the valves.
Precisely. In fact, because of that profound vasodilation, a pregnant client's blood pressure actually drops slightly through the first and second trimesters. It reaches its lowest point midway through the pregnancy before gradually returning to her baseline in the third trimester.
Wow. But her heart still has to pump all that extra fluid.
Yeah.
The pump is working harder.
It is working much harder. Cardiac output and stroke volume peak right along with the blood volume. The maternal heart rate increases, sometimes resting at 15 to 20 beats per minute higher than her normal baseline.
So she's constantly doing light cardio.
Basically, yeah. Her heart is quite literally working out 24 hours a day, 7 days a week. You will even see the left ventricular wall thicken. The heart muscle itself physically enlarges to handle the increased workload.
Okay, so the volume is way up, the pikes are wider. But let's talk about what's actually in that blood. I know from the source text that a pregnant client's hematocrit decreases. But hematocrit is just the percentage of red blood cells in the total blood volume, right?
That's right.
So if her body is making 30 to 50% more blood, shouldn't she be making more red blood cells to carry oxygen to the fetus? Why does the percentage go down?
She is making more red blood cells. Her red blood cell mass increases by about 20 to 30%. But here's the critical physiological mechanism. Her plasma volume, the liquid watery part of the blood, increases by up to 50%.
Oh, I see. The liquid expands much faster than the solid cell.
Exactly. So imagine a glass of water with 10 drops of red food coloring. That's your baseline. Now pour in another massive cup of clear water, but only add 2 more drops of red coloring.
Right. You technically have more red dye than you started with, but the overall liquid looks much lighter and more diluted.
That is hemodilution. The hematocrit percentage drops, which actually makes the blood thinner. It decreases the blood viscosity.
But why on earth does the body want thinner blood? Wouldn't you want, like, nutrient-dense, thick blood going straight to the baby?
You want flow. The goal is to lower the resistance in the utero-placental circulation. Thinner, less viscous blood flows much more easily through the tiny, intricate, highly pressurized vessels of the placenta.
Make it easier on the pump.
Exactly. It ensures the fetus gets a steady, low-resistance, continuous supply of oxygen and nutrients without the maternal heart having to pump against sludge.
That evolutionary logic is amazing. But it brings us right to a major clinical trap that nursing instructors love to test on. How do you, as the nurse, look at a lab report and tell the difference between this normal, expected, physiological anemia of pregnancy and a true pathological iron deficiency anemia that requires actual intervention?
That is a fundamental safety question. And you have to know the cutoff values. Because of hemodilution, we expect the hemoglobin and hematocrit to look a little low.
So we don't freak out.
Right. We don't panic over a hemoglobin of 11.5 grams per deciliter in a pregnant client, whereas we might flag that in a non-pregnant patient. However, if that hemoglobin drops below 11 grams per deciliter in the first or third trimester, or below 10.5 in the second trimester, that crosses the line.
So at that point, the clear water isn't just diluting the red drops. The body has actually stopped making enough red drops altogether.
Correct. That is true iron deficiency anemia. The fetal demand for iron has completely depleted the maternal stores. At that point, your priority nursing action is iron supplementation.
And there are specific rules for taking iron, right? Like patient teaching.
Huge teaching points for pharmacology here. You must instruct the client to take that iron supplement with a source of vitamin C, like a glass of orange juice.
Because the acid helps it absorb.
Yes, an acidic environment significantly increases iron absorption. And you have to teach them to avoid taking it with milk or antacids, which will block absorption entirely.
Let's talk about another massive change in the blood, the clotting factors. The source text notes that a pregnant client has a 5 times higher risk of developing a blood clot compared to a non-pregnant state. Her blood is essentially hypercoagulable. Why does the body do this?
Again, it's an evolutionary survival mechanism. The body knows that at the end of this 9-month journey, a massive organ, the placenta, is going to rip away from the highly vascular wall of the uterus.
Ouch. Yeah?
Right? Labor and birth involve significant blood loss. By naturally elevating her clotting factors, the maternal body is pre-compensating for that eventual trauma. It is preparing to quickly seal off those bleeding vessels to prevent the mother from hemorrhaging to death.
But that survival mechanism comes with a huge risk while she's still pregnant. Like a 5 times higher risk of clots is terrifying.
A massive risk. Which brings us to a critical priority nursing action. Let's run a clinical scenario. You are the triage nurse on the OB floor. A client at 32 weeks gestation walks in. She says, I'm having severe shortness of breath, and as you assess her, you notice sudden pronounced facial edema-like swelling around her eyes and her cheeks. What is running through your clinical mind?
Well, I'm certainly not telling her to go home, put her feet up, and drink some water.
Absolutely not. This is a drop everything, emergent assessment. Severe shortness of breath in a hypercoagulable patient. You must immediately suspect a pulmonary embolism, a blood clot that has traveled to her lungs, likely stemming from a deep vein thrombosis in her legs.
And what about the sudden facial edema?
That is a hallmark cardinal warning sign for severe preeclampsia. Swelling in the feet and ankles at 32 weeks is expected gravity at work. Swelling in the face and hands is an acute fluid shift caused by vascular damage.
So you are simultaneously working her up for a life-threatening clot and life-threatening hypertension. That's intense.
Exactly. You are checking her oxygen saturation, listening to her lung sounds, getting a stat blood pressure, checking her urine for protein, and notifying the provider immediately. You anticipate orders for a VQ scan or a CT angiogram, and you prepare for a potential emergency delivery.
While we're on the cardiovascular system, what is a priority teaching action for a completely healthy client regarding her blood flow and how she sleeps?
You must heavily emphasize left lateral positioning, teach the client to sleep on her left side, and to absolutely never lie flat on her back, especially from the second trimester onward.
Because of the weight of the uterus?
Exactly. Picture the anatomy. The inferior vena cava is a massive, low-pressure vein that runs right up the right side of the spine, returning all the deoxygenated blood from the lower half of the body back up to the heart.
Okay, I'm picturing it.
If a pregnant client lies flat on her back, the heavy, gravid uterus, which is full of baby, placenta, and amniotic fluid, presses directly down on that vein.
Oh, it's like stepping on a garden hose.
It completely occludes the blood return. If blood can't get back up to the heart has nothing to pump out. Cardiac output plummets. The client will experience what we call supine hypotension.
What does that feel like for her?
She will suddenly feel dizzy, lightheaded, pale, and clammy. And more importantly, if blood isn't leaving the heart, oxygen isn't reaching the placenta. Fetal oxygenation will drop precipitously, and you will see late decelerations on the fetal monitor. Rolling her onto her left side shifts the weight of the uterus off that vein, immediately restoring blood flow.
Okay, so the plumbing is working in overdrive. We have to keep the hose unkinked. What about the ventilation system? Let's look at the respiratory changes. The blood is pumping faster, cardiac output is up, so oxygen demand is naturally up. But the physical space for the lungs is shrinking because that growing uterus is pushing up on the diaphragm. How does she compensate?
It's a fascinating structural adaptation. The total vertical volume of the lungs does decrease. The diaphragm gets shoved upward by as much as 4 centimeters. It physically becomes harder to take a deep, pulling breath.
So what does the body do?
To compensate, the chest wall actually expands outward. The structural diameter of the ribcage widens.
The house literally pushes its walls out.
Yes. The ligaments of the ribcage relax to allow the lower ribs to flare. And chemically, progesterone lowers the threshold for carbon dioxide. It makes the respiratory center in the brain highly sensitive to CO2.
Interesting. So what's the result of that?
As a result, pregnant clients will often experience mild, chronic hyperventilation. They take slightly deeper, more frequent breaths to blow off extra carbon dioxide.
Which creates a mild respiratory alkalosis.
Exactly. And that mild alkalotic state is actually beneficial because it creates a concentration gradient that helps to pull carbon dioxide out of the fetal bloodstream across the placenta and into the maternal bloodstream to be exhaled.
So the mother is hyperventilating so the baby can exhale. That is incredible. But does the mother ever get relief from that upward pressure on her lungs?
She does, usually right at the end of pregnancy. There is an event called lightening. This occurs when the fetus descends and engages lower into the maternal pelvis, preparing for birth.
The baby drops.
Right. When the baby drops, that upward pressure on the diaphragm is suddenly relieved. The client will often say, "I feel like I can finally take a full breath again." But of course, there's a trade-off.
Because now the baby's head is sitting directly on her bladder.
Exactly. Which brings us perfectly to the genitourinary system. The kidneys in a pregnant client are working overtime. Because the cardiac output is so high, a massive amount of extra blood is rushing through the renal system.
They must get bigger, right?
They do. The kidneys actually physically increase in size and weight by about 30%.
And their filtration rate goes up too.
Dramatically. The glomerular filtration rate, or GFR, which is a measure of how fast the nephrons in the kidneys are filtering the blood, jumps by a staggering 50% above her baseline. The kidneys are acting like a hyper-efficient water filtration plant, clearing both maternal and fetal waste products.
But if they are filtering that fast, doesn't that affect how we interpret her urine tests?
It changes everything, and this is a major area where you have to separate expected findings from concerning pathologies. Because the GFR is so rapid, the renal tubules can't always reabsorb everything perfectly. It's like a conveyor belt moving too fast.
So things fall off the belt.
Exactly. So, seeing mild glycosuria, a tiny bit of sugar in the urine, or trace proteinuria, a tiny bit of protein, is an expected, normal finding. A little bit simply spills over the threshold.
But when does that little bit become a massive red flag? Like, what are we looking for on the dipstick?
When it stops being trace. Significant increases in proteinuria are a hallmark diagnostic indicator of preeclampsia. It means the blood vessels in the kidneys are sustaining endothelial damage, and large protein molecules are tearing through the filter.
And what if the sugar is high?
If the glycosuria is persistently high, we are looking at gestational diabetes. The maternal blood sugar is so elevated that the kidneys are desperately trying to dump the excess out through the urine.
Okay, let's talk about the symptom of urinary frequency, because this is a classic NCLEX trap. A client complains of having to pee constantly at 8 weeks gestation, and another client complains of the exact same thing at 36 weeks. It's the same symptom, but the underlying mechanisms are totally different, right?
Completely different. In the first trimester, at 8 weeks, the uterus is still tiny. It's nestled deep inside the pelvic cavity. It is not heavy enough to crush the bladder.
Oh, so why is she peeing all the time?
The urinary frequency in the first trimester is purely chemical and hemodynamic. The massive hormonal surges of HCG and progesterone cause increased pelvic congestion and increased blood flow to the bladder, which makes it hyperirritable. Plus, the kidneys are already ramping up that GFR.
So it's chemical sensitivity. But in the third trimester?
In the third trimester, it is entirely mechanical. You have a massive, heavy, fluid-filled uterus physically sitting directly on top of the bladder. It leaves almost zero physical capacity for urine to collect. The bladder fills with 2 ounces of urine, hits the wall of the uterus, and sends a signal to the brain that it's completely full.
All right, let's round out the physiological house renovation with the gastrointestinal system. The stomach is obviously getting displaced upward by the growing uterus, but the changes aren't just mechanical pushing, are they? It's chemical.
It is deeply chemical, and to lock this in, I want to introduce a memory anchor that you can use for your exams and your clinical practice. Write this down. Progesterone slows it down, relaxin loosens it up.
Okay, let's unpack that. Progesterone slows it down.
Progesterone is the ultimate smooth muscle relaxant. Smooth muscle is the involuntary muscle that lines your hollow organs. Progesterone's primary job is to relax the smooth muscle of the uterus to prevent it from contracting and rejecting the pregnancy.
But hormones circulate systemically.
Right. Progesterone doesn't just target the uterus, it relaxes smooth muscle everywhere, including the entire gastrointestinal tract.
So the whole digestive conveyor belt just hits the brakes.
Exactly. It causes delayed gastric emptying. Food sits in the stomach longer, which contributes to nausea. It decreases intestinal motility, meaning stool moves incredibly slowly through the colon.
And as it sits there,
the colon absorbs more and more water out of it, leading to severe chronic constipation.
And what about heartburn? Why is that so common?
Because of the cardiac sphincter, the little muscular door between the esophagus and the stomach, progesterone relaxes that sphincter, making it floppy.
Uh-oh.
Yeah, combine a floppy door with a stomach that is being physically squeezed upward by a growing uterus, and stomach acid easily sloshes back up into the esophagus, causing severe pyrosis or heartburn.
Okay, so progesterone slows it down. What about relaxin loosens it up?
Relaxin is another brilliant pregnancy hormone. Its specific job is to loosen the joints, ligaments, and cartilage in the body. Evolutionarily, it's designed to make the rigid bones of the maternal pelvis pliable so that they can actually shift and widen to allow a fetal head to pass through the birth canal.
But just like progesterone, relaxin doesn't stay localized to the pelvis.
Right, it loosens everything. This is why pregnant clients develop a classic waddling gait. Their pelvic joints are literally hypermobile. It's why they experience severe lower back pain. The ligaments supporting the spine are lax.
And doesn't it affect the hands, too?
Mm-hmm.
I've heard of clients getting carpal tunnel syndrome during pregnancy.
Yes. That is a direct result of relaxin combined with fluid retention. The ligaments in the wrists loosen. which allows the retained fluid to shift and compress the median nerve in the carpal tunnel.
That sounds painful.
It is. The client will complain of numbness, tingling, and sharp pain in their hands, especially at night. It's an expected physiological change, but your nursing action is to recommend wrist splints and reassure them that it typically resolves postpartum when the fluid shifts back and the relaxin drops.
That is a perfect transition. We've just mapped out the incredible structural and plumbing changes, the X-ray we had to throw out the window, basically.
Yeah.
Now let's look closer at the chemical architects forcing this renovation. Let's move into segment 2. The hormone hierarchy, who does what?
Yes. There are 6 essential pregnancy hormones that you absolutely must understand to anticipate clinical interventions. They are the project managers of this entire physiological operation. They dictate every single change we just discussed.
Let's start with the one that kicks everything off. Human chorionic gonadotropin, or HCG.
HCG is the very first player on the board. It is produced by the fertilized egg almost immediately after implantation. This is the exact hormone that a home pregnancy test or a serum blood test detects. It rises rapidly in the first trimester, peaking around 8 to 10 weeks.
But its job isn't just to turn a stick pink, right?
Yeah.
What is its physiological purpose?
Its crucial job is to rescue and maintain the corpus luteum. When a woman ovulates, the ruptured follicle on her ovary becomes a temporary cyst called the corpus luteum. If she doesn't get pregnant, that cyst dies, hormone levels drop, and she gets her period.
And if she does get pregnant?
If an embryo implants, it pumps out HCG, which signals the corpus luteum to stay alive. The corpus luteum then pumps out massive amounts of progesterone and estrogen to sustain the highly vascular uterine lining until the placenta is fully formed and can take over hormone production around 10 to 12 weeks.
But that massive, rapid spike in HCG in the first trimester has clinical side effects, doesn't it?
It does. High levels of HCG are the primary culprit behind early pregnancy, nausea, and vomiting, commonly called morning sickness. A little bit of nausea is an expected presumptive sign of pregnancy. But as a nurse, your priority action is monitoring for when that crosses the line into a pathology called hyperemesis gravidarum.
How do you differentiate typical morning sickness from hyperemesis?
Morning sickness might make a client throw up once a day, but they can still hold down fluids and maintain their weight. Hyperemesis gravidarum is severe, relentless, intractable vomiting. We are talking about clients who cannot hold down a sip of water.
That sounds incredibly dangerous for both of them.
It is. It leads to dangerous weight loss, profound dehydration, severe electrolyte imbalances like hypokalemia, dark concentrated urine, and tachycardia as the heart tries to compensate for the fluid loss.
If a client comes into triage with hyperemesis, what are our immediate nursing priorities?
Your first priority is establishing IV access for fluid resuscitation and electrolyte replacement. We also administer scheduled antiemetics like ondansetron.
And after they're stabilized?
Once they are stabilized, your teaching action revolves around diet. We recommend the Brat diet: bananas, rice, applesauce, toast, and tea because those are bland and easy to digest. We suggest ginger in the form of tea or candies, which has proven antiemetic properties.
Do you tell them to eat 3 meals a day?
No. Crucially, we teach them to eat small, frequent meals. An empty stomach actually triggers more nausea because the gastric acid has nothing to break down. Keep a cracker by the bed and eat it before even lifting your head off the pillow in the morning.
Okay, the second hormone in our hierarchy, progesterone. We've talked about how it relaxes smooth muscle, but let's cement its specific role in the uterus.
Progesterone is the protector. It is the ultimate progestation hormone. It maintains the thick, nutrient-rich lining of the uterine wall, supports blood vessel growth, and it aggressively suppresses uterine contractions.
Keeps the peace.
Exactly. It keeps the environment calm, quiet, and perfectly stable so the fetus can grow undisturbed.
Which perfectly contrasts with another hormone on our list, oxytocin.
Yes, this is one of the biggest exam traps you will face. Instructors love to test if you know the difference between progesterone and oxytocin because they both target the uterus, but they do the exact opposite things.
If progesterone is the protector that keeps things quiet, oxytocin is the eviction notice.
That is a perfect analogy. Oxytocin is the powerful engine that drives labor. It is released by the posterior pituitary gland, and it stimulates the uterine smooth muscle to contract forcefully. It also triggers the release of prostaglandins, which physically soften and whiten the cervix, allowing it to dilate.
So if you mix up progesterone and oxytocin in your mind, you're going to fail prioritization questions.
You will, because if a client comes in at 28 weeks in active preterm labor, your goal is to stop those contractions. You want to administer tucolytic medications like terbutaline or magnesium sulfate, which mimic the relaxing effects of progesterone.
And you definitely don't want to add oxytocin to that mix.
Right, and you absolutely want to avoid any intervention that might stimulate the natural release of oxytocin, like nipple stimulation. Conversely, if a client is at 41 weeks and we want to induce labor, we administer synthetic oxytocin, known as Pitocin, to start the engine.
What about estrogen? We know it's soaring during pregnancy.
Estrogen is the builder. If progesterone maintains the house, estrogen builds the additions. It promotes explosive blood vessel growth, which is why clients get that pregnancy glow, or conversely, why they get spider veins and nasal congestion. It is vital for the development of fetal organs.
And it preps the breasts.
Yes. Alongside our next hormone, prolactin, it prepares the mammary glands for eventual lactation.
All right, prolactin. The name kind of gives it away. Prolactation.
Very straightforward. Prolactin stimulates the extreme growth of the glandular breast tissue and is the primary chemical messenger responsible for the actual synthesis and production of breast milk.
But they aren't lactating heavily during pregnancy. Why is that?
While estrogen and progesterone are high during pregnancy, they actually block prolactin from releasing milk. But the moment the placenta detaches at birth, estrogen and progesterone plummet, the blockade is lifted and prolactin takes over.
Okay, the final hormone in our essential six, human placental lactogen, or HPL. The source text notes that HPL acts as a general growth hormone, but it has a very specific, testable metabolic function.
Yes. HPL is a powerful insulin antagonist. It actively contributes to maternal insulin resistance.
Wait, I need to push back on that. Why does the maternal body intentionally make its own cells resistant to insulin? Insulin is how we get glucose out of the blood and into the cells for energy. If the cells are resistant, the sugar just stays in the blood. That sounds like a fast track to diabetes, which sounds incredibly dangerous.
You are absolutely right. It is dangerous, but evolutionary biology is ruthless. The placenta secretes HPL with one specific goal: feed the fetus.
Okay, how does making the mother resistant to insulin feed the fetus?
Well, insulin's job is to pull glucose out of the maternal bloodstream into the maternal cells. But the fetus needs that glucose to rapidly grow its brain and body. So HPL blocks the mother's insulin from working efficiently.
Oh, wow. It's sabotaging the mother's supply chain.
Exactly. By making the mother's cells resistant to insulin, a higher concentration of glucose remains floating in her bloodstream for a longer period of time. This creates a high glucose gradient, ensuring a massive, steady supply of sugar crosses the placenta to feed the baby.
What does the mother use for energy then?
The maternal body shifts to burning fat for its own energy, saving the premium glucose for the fetus.
So the body is literally stealing from the mother to guarantee the survival of the fetus.
It is a delicate, precarious balancing act. In a healthy pregnancy, the mother's pancreas simply compensates. It realizes the cells are resistant, so it pumps out twice as much insulin to overcome the HPL blockade. But if her pancreas cannot keep up with that massive demand, her blood sugar stays chronically elevated.
And that is gestational diabetes.
Exactly. The very mechanism designed to ensure the baby gets fed is the exact same mechanism that triggers the pathology. This is why we screen every single pregnant client for gestational diabetes in the second trimester, right when HPL levels are peaking.
That is a total light bulb moment. The pathophysiology suddenly makes perfect sense. All right, we've covered the structural changes and the hormonal triggers. Now let's talk about the clinical application in segment 3. How does this physiological knowledge translate to the very first time a nurse assesses a pregnant client? Let's walk through the critical first prenatal visit.
This first visit is foundational. It establishes the baseline for the entire next 9 months of care. As a nurse, you are doing a massive amount of data collection, risk assessment, and teaching all at once.
Let's start with how we actually confirm the pregnancy. The source text breaks the signs of pregnancy down into 3 very specific categories: presumptive, probable, and positive. This is a massive area for exam traps.
It is. I want you to think of these 3 categories as a ladder of certainty. Presumptive signs are at the bottom rung. These are the things the client feels. They are subjective changes that make the client presume she might be pregnant.
Like amenorrhea missing a period, or nausea, fatigue, breast tenderness, and urinary frequency.
Correct. But they are only presumptive because they are not diagnostic. You could miss a period because you are highly stressed or have a thyroid issue or an elite athlete. You could have nausea from food poisoning. You could have fatigue because you work night shifts. Presumptive signs are clues, nothing more.
Okay, so we step up a rung to probable signs.
Probable signs are objective findings. These are things the healthcare provider detects during an examination or specific laboratory tests. A positive serum or urine HCG test is a probable sign.
Wait, I have to stop you there. Because if a patient takes a pregnancy test at home and it has 2 pink lines, she is going to run out of the bathroom screaming, "I'm positive! It's positive!"
And that is exactly where the nursing instructors will trap you on an exam. A positive home pregnancy test or even a blood test at the doctor's office is not a positive sign of pregnancy. It is a probable sign.
Why? If the hormone is there, isn't there a baby?
Not always. The test only detects the presence of the HCG hormone. But there are rare pathological conditions that can produce massive amounts of HCG without a viable fetus ever existing.
Like what?
For example, a molar pregnancy, which is an abnormal growth of trophoblastic tissue in the uterus, will turn a pregnancy test blazing positive, but there is no baby. Certain ovarian tumors can also secrete HCG, so a test alone is only probable.
That is a phenomenal distinction to keep in mind. What are the other probable signs?
They are physiological changes to the reproductive organs that the provider can physically feel or see during a pelvic exam. You need to know 3 specific signs. First is Goodell's sign, which is the physical softening of the cervical tip. Before pregnancy, the cervix feels firm, like the tip of your nose. Goodell's sign means it has softened to feel more like your lips.
What causes that softening?
Increased pelvic congestion and the influence of estrogen and progesterone breaking down the collagen fibers. The second is Chadwick's sign. This is a deep bluish-purple discoloration of the cervix and vaginal mucosa.
Now, normally if I see tissue turning purple, I assume it's cyanotic. I assume it's dying from lack of oxygen.
It's a great instinct, but in this case, it's the exact opposite. It's not a lack of oxygen, it's an extreme abundance of venous blood. Estrogen promotes massive vascularity to the pelvic region. All that extra blood pooling in the tiny veins of the cervix gives it a dark blue or purple hue. It can appear as early as 6 weeks.
Wow, okay. And the third?
And the third is Hegar's sign, which is a softening and compressibility of the lower uterine segment right above the cervix.
So we have presumptive what she feels and probable what we test or feel. What is the top rung of the ladder? The positive signs.
Positive signs are absolute, undeniable, bulletproof proof that a fetus exists. There is no other medical explanation, and there are only 3 of them. Visualizing the fetus on an ultrasound, hearing the fetal heart tones with a Doppler or fetoscope, or the provider actively feeling fetal movement during an examination. If you don't have one of those 3, you do not have a positive sign of pregnancy.
Okay, so once we confirm the pregnancy with an ultrasound or Doppler, the very next question out of the patient's mouth is going to be, when is my baby due? How do we calculate that?
We use a standardized formula called Naegele's rule to calculate the estimated date of birth, or the EDB. The formula is, take the first day of the client's last menstrual period, the LMP, subtract 3 months, then add 7 days, and adjust the year if necessary.
Let's do a concrete example so everyone can follow the math. A patient comes into the clinic. She says the first day of her last normal menstrual period was September 10th.
Okay, September 10th. First, we go backward 3 months from September. That takes us to August, July, June. So we are at June 10th. Next, we add 7 days to the 10th. That gets us to the 17th. So her estimated date of birth is June 17th of the following year.
Why do we subtract 3 months and add 7 days? That seems so arbitrary.
It's based on a standard 28-day menstrual cycle, assuming ovulation and conception happen on day 14. Adding 7 days adjusts for that 2-week gap between the start of the period and actual conception, and subtracting 3 months effectively adds 9 months to the calendar to reach the 40-week gestation mark. It's a quick, reliable clinical estimation, though early ultrasounds are ultimately the most accurate dating method.
Speaking of math, let's tackle the obstetrical history. The famous GTPL system. Gravida, term, preterm, abortion, live-in. This is where nursing students just stare blankly at their exam screens.
It's where dreams go to die if you don't know the specific rules of parity. Let's define the terms cleanly before we do an example. Gravida simply means the total number of times a woman has been pregnant, regardless of the duration or the outcome. If she is currently pregnant, that counts as 1.
Okay.
Term is the number of pregnancies carried to 37 weeks gestation or beyond.
Preterm.
Preterm is the number of pregnancies delivered between 20 weeks and 36 weeks and 6 days.
Abortion.
Abortion is any pregnancy loss, whether it is a spontaneous miscarriage or an elective termination, that occurs prior to 20 weeks gestation.
And living.
Living is simply the total number of living children the client currently has.
Okay, let's walk through a highly complex, classic NCLEX-style trap scenario from the source material. A pregnant client is sitting in your triage room. She tells you her history. She's previously birthed 2 full-term children who are currently ages 3 and 5. She also has a set of twins born prematurely at 28 weeks who are both living, and she has had 1 miscarriage at 10 weeks. Let's calculate her GTPL.
Okay, let's break this down systematically. First, gravida. How many individual times has she been pregnant? She is pregnant right now in your triage room. That is pregnancy number 1. She had the 2 full-term kids, assuming those were separate pregnancies, that is pregnancy 2 and pregnancy 3. She had a pregnancy with the twins, that is pregnancy number 4. And she had the miscarriage, that is pregnancy number 5. So gravida is 5, G5.
Okay, term. How many deliveries at 37 weeks or later?
She has the 2 full-term children, so term is 2.
Preterm. Deliveries between 20 and 36 weeks.
The twins were born at 28 weeks. Here is the massive critical trap that will ruin your score. Twins, triplets, any multiples count as 1 pregnancy and 1 delivery for the sake of parity. They do not count as 2 preterm deliveries. You are counting the delivery event, not the number of babies that came out. Therefore, her preterm delivery number is 1.
Wow. Okay, so term is 2, preterm is 1. What about abortion?
She had 1 miscarriage at 10 weeks, which is before the 20-week cutoff, so abortion is 1.
And finally,
living. She has the 2 full-term kids, and the twins are both living, so she has 4 living children.
so her GTPL string is 52114. And if an instructor asks for just her gravida and parity, her G and P, she's G5P3, because parity is the total number of deliveries after 20 weeks. That's the 2 full-term deliveries plus the 1 preterm twin delivery.
Exactly. Instructors will always use twins or multiples to mess up your preterm and living numbers. The memory anchor here is multiples count as 1 pregnancy, 1 delivery, but multiple living children.
That clears up so much confusion. Beyond the math and the dates, what are our absolute priority nursing actions during this first prenatal visit? We're collecting a lot of sensitive data.
Your overarching priority is establishing a safe, non-judgmental therapeutic baseline. This is the window where you must ask direct, difficult questions. You screen for substance use. If a client smokes, you don't just tell them smoking is bad. You explain the physiology.
What's the physiological risk there?
Nicotine causes extreme vasoconstriction. It clamps down the blood vessels in the placenta, severely restricting oxygen and nutrients to the fetus, which dramatically increases the risk of intrauterine growth restriction, low birth weight, and preterm labor.
You also screen for sexually transmitted infections, right?
Yes, comprehensive STI screening is mandatory because many infections like syphilis or chlamydia can cross the placenta or infect the baby during vaginal delivery, causing devastating congenital anomalies or blindness. But perhaps the most critical, often overlooked priority assessment during this first visit is screening for intimate partner violence.
Why is that specifically highlighted in the OB context?
Because the risk, frequency, and severity of intimate partner violence often escalate dramatically during pregnancy and the immediate postpartum period. The shifting relationship dynamics, the financial stress of a new baby, the physical changes in the maternal body, all of these can trigger an abusive partner to exert more control.
How does a nurse properly screen for that? Because a victim isn't just going to volunteer that information with their abuser sitting right next to them in the room.
They absolutely will not. The nursing priority is that you must separate the client from their partner to ask these questions. You find a reason taking them to the bathroom for a urine sample or bringing them to a separate room for an ultrasound prep.
And then what do you say?
Once you are alone, behind a closed door, you use direct, normalizing language. Because violence is so common in our society, we ask every single pregnant patient, is anyone hurting you, threatening you, or making you feel unsafe at home? You establish yourself as a safe harbor from day one.
And physically, what do we check on the baby during this first visit?
Depending on how far along she is, we assess the fetal heart rate. By 10 to 12 weeks, we can usually pick it up with a handheld Doppler. We are listening for a baseline heart rate between 110 and 160 beats per minute. That fast rhythm is a crucial indicator of fetal well-being.
All right, let's transition into the deep waters of maternal fetal medicine. Segment 4. Pharmacology, labs, and immunizations. Once we establish the history and the physical baseline, we have to draw the blood. And looking at this source material, infection control and pharmacology are massive, high-stakes priorities.
They are the safety net of the entire pregnancy. Let's look at the initial prenatal lab panel. You draw a complete blood count to establish a baseline hematocrit and hemoglobin to monitor that physiological anemia we discussed. We check her rubella titer to see if she has immunity to German measles. We do comprehensive infectious disease screening, HIV, hepatitis B surface antigen, and an RPR or VDRL test, which screens for syphilis.
And we also check blood type and Rh factor. Let's dive deep into this because ROGAM is probably one of the most tested pharmacological interventions in all of nursing. Who gets it? When do they get it? And most importantly, why?
The rule is absolute. Only clients who are Rh negative receive ROGAM. The Rh factor is a specific protein found on the surface of red blood cells. If you have it, you are positive. If you don't have it, you're negative. If an Rh negative mother is carrying an Rh positive fetus, we have a potentially lethal incompatibility.
Let's walk through the pathophysiology of that. What actually happens if an Rh negative mom's blood mixes with her Rh positive baby's blood?
Normally, maternal and fetal blood do not mix. The placenta acts as a barrier. But during delivery, or if there is trauma like a car accident or a procedure like an amniocentesis, fetal blood cells can cross over into the maternal bloodstream.
And her body notices.
Yes, the mother's immune system detects those Rh positive red blood cells. Because she is Rh negative, her body has never seen this protein before. Her macrophages identify it as a dangerous foreign invader, no different than a deadly virus or bacteria.
So her immune system mounts an attack.
It launches a full-scale immunological war. Her B cells begin producing massive amounts of antibodies specifically designed to hunt down and destroy Rh-positive red blood cells. This process is called Rh isoimmunization or sensitization.
But does this attack hurt the baby she's currently carrying?
Usually no. The first pregnancy is typically safe because the significant blood mixing usually happens at the moment of delivery, as the placenta detaches. By the time her immune system manufactures the antibodies, the first baby has already been born.
But the body have a memory.
A permanent memory. Those antibodies stay in her bloodstream forever. If she gets pregnant again, and that second fetus is also Rh positive, those tiny maternal antibodies will cross the placenta, enter the fetal bloodstream, and aggressively, systematically destroy the baby's red blood cells.
Oh my God.
It causes severe, often fatal hemolytic disease of the newborn, profound fetal anemia, heart failure, and hydrops fetalis.
It is devastating. So how does ROGAM stop this from happening?
ROGAM RO'd immune globulin is essentially an invisibility cloak. It is an intramuscular injection of synthetic anti-D antibodies. If fetal cells cross into the maternal bloodstream, the ROGAM swoops in, binds to those fetal cells, and hides them.
Right to them.
It destroys them before the mother's own immune system ever realizes they are there. Because her immune system never sees the foreign protein, it never learns how to make the destructive antibodies.
That is brilliant pharmacology. So what is the precise protocol? When does the nurse administer this invisibility cloak?
For an Rh-negative client, we administer a routine prophylactic dose at 28 weeks gestation because that is when the placenta becomes more permeable. Then, after she delivers, we test the baby's blood type.
And if the baby is Rh positive?
If the baby is Rh positive, the mother must receive a second dose of ROGAM within 72 hours of delivery to sweep up any cells that transferred during birth.
And if the baby is born Rh negative?
If the baby is Rh negative, they match the mother. There is no foreign protein, no risk of sensitization, and no postpartum ROGAM is needed. And remember, we also give ROGAM anytime there is a bleeding event, a miscarriage, an ectopic pregnancy, or abdominal trauma where blood might have mixed.
What are the primary exam traps regarding ROGAM?
The easiest trap to fall for in a high-stress exam is misreading the patient's blood type. The question will describe an Rh-positive client who just had an amniocentesis and ask what your priority action is. One of the options will be administer ROGAM. If you click it, you fail the question.
Because she's already positive.
Exactly. An Rh-positive client already has the protein. Her body will never attack it. Never give ROGAM to an Rh-positive client.
Let's talk about another massive infection risk. Group B streptococcus, or GBS. What is it and why are we so worried about it?
Group B strep is a very common bacteria. It naturally colonizes the vaginal and rectal flora in about a quarter of all healthy women. It causes absolutely no symptoms and no harm to the mother. She doesn't even know she has it.
But it's dangerous for the baby.
Highly dangerous. As the fetus descends through the birth canal during a vaginal delivery, they are covered in maternal fluids. If they aspirate or ingest that GBS bacteria, their immature immune systems cannot handle it. It can lead to rapid onset, severe neonatal sepsis, pneumonia, or meningitis within hours of birth.
So what is the priority nursing action? How do we prevent this?
We screen every single pregnant client with a vaginal rectal swab between 36 and 37 weeks gestation. If the culture comes back positive, our priority is administering 5E antibiotics, typically penicillin G or ampicillin.
But wait, if we know she's positive at 36 weeks, why don't we just give her the antibiotics right then and there to clear it out before labor even starts?
Because it won't work. The gastrointestinal tract is a reservoir for GBS. Even if you eradicate it from the vagina at 36 weeks, it will recolonize within days. Giving oral antibiotics early is useless.
So when do we give it?
The clinical strategy is to administer the IV antibiotics during active labor, typically every 4 hours until delivery. We want the antibiotic actively circulating in the maternal bloodstream, crossing the placenta, and providing peak protective levels in the fetus at the exact moment they are navigating the birth canal.
It's precision timing. Speaking of precise timing, let's tackle immunizations. This is another massive area for test questions. Let's look at the trap of live versus dead vaccines. A client is at her first prenatal visit. You draw her labs, and you discover her rubella titer is non-immune. Do we give her the MMR vaccine right then in the clinic to protect her?
Absolutely not. You do not administer the MMR measles, mumps, rubella vaccine during pregnancy. It is strictly contraindicated.
Why? Wouldn't getting rubella be terrible for the baby?
Getting wild rubella is catastrophic for fetal development, causing deafness, cataracts, and heart defects. But the MMR vaccine is a live, attenuated virus. It contains a weakened but still living version of the virus.
Oh, and her immune system is suppressed.
Exactly. Because the maternal immune system is intentionally suppressed during pregnancy, there is a theoretical risk that the live vaccine virus could cross the placenta and actually cause the congenital infection we're trying to prevent.
So what is the nursing action?
We teach her to avoid exposure to anyone with a rash or viral illness. And our absolute priority is to administer the MMR vaccine in the immediate postpartum period, before she is discharged from the hospital, to protect her in future pregnancies. We also instruct her not to get pregnant for at least 28 days after receiving it.
But are all vaccines contraindicated? Because that's the second half of the trap.
Yeah.
Students assume pregnancy equals no vaccines.
That is a dangerous assumption. Only live vaccines are contraindicated. So no MMR, no varicella, no live nasal flu spray. However, inactive or dead vaccines are highly recommended and critical for safety. We actively encourage the seasonal injectable flu shot. And we mandate the Tdap vaccine, tetanus, diphtheria, and pertussis in the 3rd trimester of every single pregnancy.
Why every pregnancy? Even if she had one 2 years ago.
Yes. We are giving the Tdap specifically for the pertussis component whooping cough. Pertussis is deadly to newborns. By vaccinating the mother in the 3rd trimester, her body creates a massive surge of antibodies that cross the placenta, providing the newborn with vital passive immunity to whooping cough until they are old enough to get their own vaccines at 2 months of age.
Before we leave infections, there's one more trap I want to cover. Toxoplasmosis. You see this trope in movies all the time. A woman gets pregnant, and she immediately forces her partner to get rid of the family cat. Is that clinically necessary?
No, you do not have to banish the cat. Toxoplasmosis is a parasitic infection that can be spread through the feces of infected cats. And if a pregnant client contracts it, it can cause severe neurological damage, cognitive disabilities, or blindness in the fetus.
So how do we prevent it without evicting the pet?
Priority teaching. The pregnant client must absolutely avoid changing the litter box. Let someone else do it. If she must do it, she must wear a mask and gloves and wash her hands immediately.
Are there other sources of toxoplasmosis?
Yes, outdoor cats defecate in soil, so if the client enjoys gardening, she must wear thick gloves when handling dirt. And finally, toxoplasmosis can live on unwashed produce, so she must rigorously wash all fruits and vegetables before consuming them.
All right, we are moving into the final stretch, segment 5, the trimester roadmap. We have established the baseline, we've navigated the first visit and the labs. Let's move chronologically through the 2nd and 3rd trimesters. What is the timeline of high-yield screenings that a nurse needs to anticipate?
Let's lay out the calendar. Between 15 and 20 weeks gestation, we offer the maternal serum screening, often called the quad screen. This is a simple blood draw from the mother that evaluates specific proteins and hormones to assess the risk of chromosomal disorders like Down syndrome trisomy 21 and open neural tube defects like spina bifida.
Is that a diagnosis?
No, it is a screening, not a diagnostic test, but it guides further intervention.
Then what happens between 18 and 20 weeks?
The comprehensive anatomy ultrasound, this is the big scan. The sonographer measures the fetal head circumference, abdominal circumference, femur length, and evaluates the heart chambers and organs to ensure structural normality.
What's the nursing teaching point for an ultrasound? I know it depends on how far along they are.
It does. Early in pregnancy, the uterus is still tucked behind the pelvic bone. So for a first trimester transabdominal ultrasound, you must instruct the client to come in with a completely full bladder.
Why a full bladder?
The full bladder acts as a wedge. It physically pushes the uterus upward and out of the pelvic cavity so the sound waves can clearly image the fetus. But by 18 to 20 weeks, the uterus has grown large enough that a full bladder is no longer necessary.
Okay, moving down the calendar. 24 to 28 weeks.
This is a massive milestone. This is the routine glucose screening test for gestational diabetes, which we discussed earlier when we talked about the HPL hormone peaking. The client comes to the clinic and drinks a highly concentrated 50-gram liquid glucose solution. Exactly 1 hour later, we draw her blood.
And what number are we looking for?
We expect the maternal pancreas to have released enough insulin to process that sugar, keeping the blood glucose level less than 140 milligrams per deciliter. If the result is 140 or higher, she has failed the preliminary screen.
So what's the next step if she fails?
The priority action is then to schedule her for a much more rigorous, fasting 3-hour oral glucose tolerance test to definitively diagnose gestational diabetes.
Let's transition into our expected versus concerning bucket for the later half of pregnancy. What should a client be feeling and what should make them run to the hospital? Let's start with quickening.
Quickening is a beautiful milestone. It is the very first time the client consciously feels fetal movement. It doesn't feel like a sharp kick. It feels like subtle flutters, butterfly taps, or gas bubbles.
When does that usually happen?
In a first-time mother, this expected finding typically occurs between 18 and 22 weeks. In a client who has been pregnant before, they recognize the sensation earlier, usually around 16 weeks.
And what about Braxton Hicks contractions? Because those terrify first-time parents.
They do, but they are completely expected. Braxton Hicks are practice contractions that occur sporadically throughout the second and third trimesters. The uterine muscle is essentially flexing and preparing for the marathon of labor. They can feel tight, uncomfortable, and even take the client's breath away momentarily.
How does a nurse teach a frantic client over the phone to tell the difference between Braxton Hicks and true, dangerous preterm labor?
You assess the pattern and the cervix. Braxton Hicks contractions are irregular. They do not get closer together, they do not get stronger over time, and most importantly, they do not cause the cervix to dilate.
So how do you test that at home?
You teach the client that if they change their activity, if they are resting, tell them to get up and walk. If they are walking, tell them to lie down and drink 2 massive glasses of water. Braxton Hicks will almost always fade away.
And true labor. What are the hallmarks?
True labor is relentless. The contractions establish a regular pattern. They increase in frequency getting closer together. They increase in duration lasting longer. And they increase in intensity getting far more painful. Changing positions or drinking water will not stop them.
And where do they feel the pain?
A classic assessment finding is that true labor pain often initiates deep in the lower back and wraps around at the front of the abdomen like a tightening belt, whereas Braxton Hicks usually just feel like localized abdominal tightening.
If a client is experiencing true labor symptoms before 37 weeks, accompanied by any vaginal bleeding, pelvic pressure, or a sudden gush of clear fluid, what is the action?
Immediate presentation to the labor and delivery triage unit. Do not wait. Preterm labor requires aggressive, immediate medical intervention to administer tocolytics to stop contractions, and betamethasone, a steroid, to rapidly mature the fetal lungs in case delivery is unavoidable.
Let's talk about fetal movement in the third trimester. Because once the baby is big enough to be felt consistently, movement becomes our best diagnostic tool.
It is the ultimate vital sign. Fetal movement is a direct reflection of central nervous system integrity and fetal oxygenation. By the third trimester, we instruct clients to perform daily kick counts to monitor fetal well-being.
How exactly does a client do a kick count?
We teach them to pick a time of day when the baby is usually active, often after a meal or in the evening. They should lie quietly on their left side, eliminate distractions, place their hands on their abdomen, and count every distinct movement, kick, or roll. They are looking to feel at least 10 distinct movements within a 2-hour window. Often, they hit 10 movements in 15 minutes.
But what if they sit there for 2 hours and they only feel 4 movements? Or 0?
If they do not feel 10 movements in 2 hours, or if they notice a sudden, drastic decrease in the baby's normal movement pattern, it is a priority to notify the provider and go to the hospital immediately.
Why does movement stop?
Think about basic survival physiology. If the placenta is failing or the umbilical cord is compressed, the fetus is not getting enough oxygen. When oxygen is low, the fetal brain triages. It shunts whatever oxygen it have to the vital organs, the heart and the brain. It stops sending oxygen to the skeletal muscles. Therefore, a fetus in distress will actively conserve energy by stopping all movement. Decreased fetal movement is a cardinal, glaring red flag for fetal hypoxia.
Is the baby waving a white flag? What if we have to do an invasive test to check on the baby, like an amniocentesis?
An amniocentesis is performed under ultrasound guidance. The provider inserts a long, thin spinal needle straight through the maternal abdomen into the uterine cavity to draw out a sample of amniotic fluid for genetic testing or lung maturity analysis.
Puncturing a house while someone is living in it. What are the priority nursing actions after that procedure?
The procedure itself carries risks. You have punctured the amniotic sac and irritated the highly vascular uterus. Post-procedure, you monitor fetal heart tones to ensure the baby tolerated it. You teach the client to go home and rest. No strenuous activities, no heavy lifting, and no intercourse for 24 to 48 hours.
And what warning signs should they watch for?
You give them strict warning signs to report immediately. Severe abdominal cramping, which could indicate preterm labor triggered by the needle, any vaginal bleeding or any leakage of clear fluid, which would mean the amniotic sac hasn't sealed and they have ruptured their membranes.
Let's connect this to our final concept before we wrap up. We talk constantly about the dangers of premature babies born before 37 weeks. But what about post-term pregnancies, babies that stay in past 42 weeks? It seems intuitive that more time baking in the oven would be better, right? Let them get bigger and stronger.
That is a very common misconception, but it is entirely false. Post-term pregnancies carry incredibly high risks of morbidity and mortality.
Why? What goes wrong?
The problem is the placenta. The placenta is an incredible organ, but it is temporary. It literally has a biological expiration date. It is designed to function optimally for about 40 weeks. As the pregnancy progresses past 40, 41, 42 weeks, the placenta begins to rapidly age, calcify, and degrade. The blood vessels infarct and die.
So the supply line gets cut off.
Yes. It leads to profound placental insufficiency. The fetus stops getting adequate oxygen and nutrients. Furthermore, as the placenta fails, amniotic fluid volume severely decreases, a condition called oligohydramnios.
And why is low fluid dangerous? Isn't the baby just less buoyant?
The fluid isn't just for swimming, it's a physical cushion. The umbilical cord is floating in that fluid. If the fluid volume drops, the heavy fetus can physically crush the umbilical cord against the wall of the uterus.
Oh, that's really bad.
It is. When the cord is compressed, the oxygen supply is instantly cut off. We see severe variable decelerations on the heart monitor. Fetal safety absolutely depends on inducing labor before that aging placenta fails completely.
Wow. Okay. We have covered a staggering amount of complex physiological ground today. We've gone from the cardiovascular surges to the hormonal blueprints, the critical labs, and the late-stage warning signs. It's time for our outro. We like to distill everything down. If our listener sitting in their car studying at their desk right now only remembers 5 things from this entire hour, what are the 5 absolute must-know takeaways?
Number 1, hormone roles. Never mix up the architects. Progesterone is the protector. It maintains the pregnancy and relaxes the smooth muscle of the uterus. Oxytocin is the engine. It forcefully stimulates contractions to drive labor.
Number 2, the ROGAM rules. This is massive for exams. ROGAM is only for Rh-negative clients. Never give it to an Rh-positive client. It acts as an immunological invisibility cloak, given routinely at 28 weeks, and crucially, it must be administered within 72 hours of the birth of an Rh-positive baby or after any traumatic bleeding event.
Number 3, the signs of pregnancy. A positive home pregnancy test is merely a probable sign. It is a clue. Only visualizing the fetus via ultrasound or physically hearing the fetal heartbeat via Doppler is a positive, absolute confirmation of a viable pregnancy.
Number 4, safety and assessment. Fetal movement is the ultimate vital sign in the 3rd trimester. A healthy baby moves. If a client feels fewer than 10 kicks in a 2-hour window, it requires immediate, emergent reporting. Decreased movement means the baby is conserving oxygen. It means danger.
And number 5, immunization safety. No live vaccines during pregnancy. That means the MMR and varicella vaccines are strictly contraindicated until the postpartum period. However, inactive vaccines like the Tdap and the seasonal flu shot are not only safe, they are urgently necessary to provide passive immunity to the newborn.
Before we officially sign off, I know you always have a final thought for us to mull over. We've talked so much about the physiological tightrope the mother walks, especially regarding her immune system. She has to turn off her defenses so she doesn't reject the fetus, which is essentially half foreign DNA. But there's a consequence to that blending, isn't there? Something that lasts far beyond those 9 months.
There is, and it is perhaps the most profound, mind-bending reality of maternal physiology. It's a phenomenon called fetal microchimerism.
What exactly is that?
We talk about the placenta being a barrier, but it is not impenetrable. Throughout the pregnancy, cells from the fetus actively cross the placenta and enter the maternal bloodstream. Because the mother's immune system is suppressed, it doesn't destroy them. Those fetal cells circulate and actually embed themselves into the mother's own organs.
Which organs?
They embed in her liver, her lungs, her heart muscle, and even cross the blood-brain barrier to live in her brain.
Wait, are you saying the baby cells become part of the mother's body?
Yes. And they don't just disappear after birth. Studies have found functional fetal cells thriving inside maternal organs decades later. A mother who gives birth carries the living cellular footprint of her child inside her own heart and brain for the rest of her life.
That's unbelievable.
It gets better. These cells have even been found rushing to sites of maternal injury, like a scarred heart after a heart attack, attempting to heal the mother's tissue.
That is absolutely staggering. The baby is literally healing the house from the inside, long after it has moved out.
It fundamentally redefines what it means to be a mother at a biological, cellular level. It proves that the physical connection between a maternal patient and a fetal patient doesn't end when you cut the umbilical cord. They are permanently intertwined.
It brings us right back to where we started today, the broken arm in the X-ray machine. In a normal medical situation, you look at an X-ray to find the single, isolated thing that is broken. You treat the individual. But in obstetrics, there is no isolated individual.
No, there really isn't.
The baseline isn't static. It's a magnificent, chaotic merging of two lives. Your job as a nurse isn't to look for a clean break. Your job is to monitor the earthquake, to understand the shifting architecture, and to keep the house standing while it's being rebuilt from the inside out.
That is the immense responsibility, the art, and the absolute privilege of being an OB nurse.
I couldn't agree more. To our listeners, as you step into your exams or onto the clinical floor, keep prioritizing safety. Always stay deeply curious about the why behind the symptoms. Remember that every abnormal lab value tells a story. And above all, learn to trust your clinical judgment. You have the knowledge. You've got this. Until next time, keep diving deep.